¿Qué tal? Buenas noches. Buenas noches.
Hello, how are you, everyone? Thank you for being here with us. This is the monthly session. This is February from Colegio Mexicano de Medicina Crítica. Thank you to all the audience in Mexico and Latin America. This is a very interesting session with a very um, important and special speaker from Italy and two of our dear colleagues, and very important regarding intensive care in our country. So we have Dr. Karina Rosa Sanchez, who is chief of the intensive therapy unit in Hospital Angeles Tijuana, Mexico, with a specialty of emergencies and critical unit. She will be joining us and will help with comments and questions. We also have Dr. Paola Verónica Romano Albornoz, who is the professor in the cardiology clinic specialty in Centro Médico, also specialist in critical medicine. And today we will be addressing a very interesting topic that I'm sure you're going to love, and it is regarding the practical approach and critical applications to diastolic dysfunction in critical care. So I'm sure that you're going to love it. And our international guest is Filippo Sanfilippo. He will be joining us from Italy. He is anesthesiologist from the hospital Universitario in Catania, and I'm sure you have heard about him. He has written different papers, especially in critical echocardiography, and he also has written different papers regarding the critical clinical application to diastolic dysfunction. And he has written, among other great authors, in this topic of critical echocardiography. So we would like to welcome our guest, Filippo Sanfilippo. This is a recorded session, and because of the different time zone, it was a little hard to setting it up live. So I'm sure that you will going to love it. So thank you and welcome to this session of Colegio Mexicano de Medicina Crítica, February, and the topic is practical approach and clinical application to diastolic dysfunction in critical care. Thank you for joining us, and let's start with our speaker. Thank you.
Okay. Let's try to discuss a bit with my Mexican colleagues about diastolic dysfunction. We will try to make a practical lecture, but also to understand a bit of physiology of diastole applied to critical care. And I have no conflict of interest. Let me see whether, yes, now the presentation is going. And in the agenda, we will define diastolic dysfunction in the field of critical illness, and we'll look at the impact of diastolic dysfunction on the outcome of this population of patients. And finally, we'll give you some suggestions for a proactive approach for the patient with diastolic dysfunction. So let's start with the first of these three parts of the lecture, and why we do apply guidelines in critical care, in echocardiography, and so on. Well, in the field of echocardiography, we try to define what is a normal function or a normal size as compared to abnormal. And when we refer normal values, of course, we refer to a healthy population stratified by gender, age, and so on. As an example, you see on the right side of the slide, LV internal dimension, LV ejection fraction, LV volumes according to the gender of male or female, and what is the mean and standard deviation in a healthy population. Of course, the patients that are in critical care are not that healthy. So that's the first difficulty when we try to apply values from guidelines to people that are critically ill. The second point regarding guidelines that I want to make is that the guidelines are useful because for many reasons, but also because they allow us to have the indication for therapy. Let's say a patient is indicated a beta blocker or not, and we can try to predict if the patient will respond to that treatment, and we can measure the outcomes, which are not only mortality, but when we look at the cardiology field, our colleagues, cardiologists, they look to reduce the need for hospitalization and so on. Now, let's now focus on diastole. What is the diastology, or the study of diastolic function? The study of diastolic function starts with the definition of what is a normal function. A normal function is a condition as simple as when the left ventricle fills with low atrioventricular gradient. So if we are managing to fill nicely the left ventricle with low atrioventricular gradient, in the presence of normal low left atrial pressure, we are in presence of normal LV diastolic function. And under this condition, we will see a dominant early to late mitral valve, transmitral valve filling. So the dominance of the E wave over the A wave. Now, the issue with diastolic function and its assessment, even outside of the critical care, is that it does not rely on a single parameter. If we compare the systolic function, we evaluate LV ejection fraction, or eventually MAPS, S prime, other parameters. But on their own, these parameters are enough to stratify the patient according to the systolic function. With the diastolic function, this function is not the same, because we need a lot of parameters that should be integrated together. And as for many other conditions, diastolic function assessment is dependent on preload and afterload. And finally, we have difficulties in defining a reference for age and gender. So it's a bit challenging, the assessment of diastolic dysfunction. And indeed, with the previous guidelines, the one issued in 2009, the assessment was quite complex, as you can see in this slide. Even though this is taken directly from the paper and the guidelines, the author defined this approach as practical. But even if this is defined as practical, what it happens is that a lot of patients will stay with indeterminate diastolic dysfunction. So it will be challenging even to diagnose if the patient has or has not diastolic dysfunction. So these guidelines were leaving people very confused and perplexed on the assessment of LV diastolic function. And the most recent guidelines, which were issued in July 2016 and is joined by the American Society of Echocardiography and the European Association of Cardiovascular Imaging, they have provided two very important, I would say, advantages. The first one is very simple, and these guidelines have clarified the relationship between systolic dysfunction and diastolic function, and you will see in the next slide. And the second great point is the simplification in the diagnosis and grading of diastolic dysfunction. So, first point is that these new guidelines basically have removed the idea of isolated LV systolic dysfunction, because once the patient has got systolic dysfunction as defined by an ejection fraction below 50 or 55%, the patient has by definition diastolic dysfunction. So a patient with 40% ejection fraction has diastolic dysfunction by definition, so we don't need anymore to diagnose it, but we just need to grade diastolic dysfunction. Okay? Regarding the second point and the attempt of the guidelines to make it easier, the diagnosis, at least we can see, as compared to the previous practical approach of 2009, that we rely now only on 4 variables. These 4 variables can be measured all in apical 4-chamber view or in apical 2 chambers view, apart from the tricuspid regurgitation jet, and basically are the E prime velocity, which is a tissue Doppler imaging parameter, which measures the velocity of the myocardium at basal level and its velocity in the relaxation, basically, early period. The E prime ratio, which is the ratio of the E wave to the E prime wave, which has a degree of correlation with the left atrial pressures, and the left atrial volume index, and finally the tracheosphere regurgitation jet velocity. These two parameters as basically a surrogate of increased pressure back on the lungs as a result of diastolic dysfunction. So in this slide, it may seem complicated, but the top one is what I just said. So is in the diagnosis, you use 4 variables, and you make diagnosis of diastolic dysfunction if the majority of these variables are abnormal. In case you get 2 normal and 2 abnormal, then we cannot diagnose LV diastolic dysfunction, and we remain with indeterminate function. It is also possible that a patient has no tricuspid jet, tricuspid regurgitation jet, and in this case, one can use the other 3 parameters to make diagnosis of diastolic dysfunction or not. To make it a bit more practical, I used this example where you see the 4 images, with the calculation. I don't pretend you go and read all these numbers here, but actually the numbers that are here, you can see that there are 3 abnormal values, which are atrial volume, tricuspid regurgitation jet velocity, and the E prime velocity, while the E prime ratio is normal. So we have 3 abnormal values out of 4. So we have made diagnosis of LV diastolic dysfunction. Once we make diagnosis, we have to move to the grading of LV diastolic dysfunction. It looks a bit more complex, but essentially we have to evaluate what is the EA ratio or the E wave velocity. And looking at this patient with 58 centimeter per second of E wave velocity and a ratio just below 0.8, we can see that we are in this box. So with EA below 0.8 and E wave more than 50. Then we have to move in these 3 parameters, and we know that 2 of them are abnormal, in particular the TR jet and the LA volume, while EE prime ratio is 9.7 here, so it's normal, okay? So in this case, we made the diagnosis of LV diastolic dysfunction 2nd degree pseudo-normal stage. Okay, this was an example to show you how it is still not that easy because it requires some the integration of some parameters. And to make it more complex, although the new guidelines have simplified the assessment, you can read the first paragraph and see that the author states that guidelines are not necessarily applicable to children or in the perioperative setting. I think they forgot about the critically ill patient, but we can assume that they meant also the critically ill patient. Why it's difficult to apply these guidelines, I tell you from a practical perspective as well, to the population of critically ill patients. It's difficult because assuming the LA volume and the TR jet velocity, for instance, 2 of the 4 parameters, in patients that are mechanically ventilated, we have an influence of pulmonary vascular resistance and therefore on tricuspid regurgitation jet. We also have patients that are exposed to variable preload and afterload and great variability according to the fluid resuscitation, according to the use of diuretics and so on, the dilatation or vasodilatation due to use of sedatives and so on. So what other authors have suggested, in particular Mike Lanspa has done a lot of work on that, is to use only the TDI variables in the critically ill patient. So E prime and the surrogate of LA pressure as E prime ratio. So this is the second of two papers published by Mike Laspa, and in this one they compared in a population of over 300 patients, if I correctly remember, the use of a simplified definition where the E prime velocity cutoff is used at 8, and in case of abnormal values of E prime, the authors basically grade the diastolic dysfunction according to the value of E prime ratio. What the authors found, it's almost 400 patients with sepsis. They found that the application of the simplified definition, the 2016 definition and the 2009 definition, yielded a basically different number of classification for diastolic dysfunction. So with the oldest guidelines, the authors were able to categorize only a third of the patient, you see 34%, while with the simplified and with the 2016 guidelines, they were able to give a category of diastolic dysfunction to basically 3/4 of the population, so at least double than what was feasible with the 2009. So the 2016 guidelines seems an improvement, and also the use of a simplified definition seems promising. It seems promising also because the authors found that the simplified definition, you see the last point of in violet line, was able to categorize patients with an association with relevant comorbidities, which were myocardial infarction, hypertension, and diabetes. So it looks promising, but from my own practice, I can tell you that I wouldn't use this simplified definition in COVID patient, for instance. COVID patient, they have mostly E prime reduced, at least the patient that arrived to the ICU, and they have very low E prime ratio, at least lowish, because they had fever, they have been dehydrated, they have been drinking for a while, and so on. We try to use diuretics to improve oxygenation and so on. So basically, the work by Mike Laspa is very practical, very good, but maybe some population of critical ill patient will not benefit from it. But this is there are room for studies in that regard. This is another study that confirms how the new guidelines are more applicable in the critically ill patient. And this is a study by Stephen Wang, Tony McLean, and the group basically of the Nepean Hospital in Sydney. What the authors found, sorry, I went, okay. So what the authors found is that applying the 2009 guidelines, both on day 1 and day 3, and both in the patient with normal systolic function or abnormal systolic function, was providing the operator with a lot of patients with indeterminate function. You can see, for instance, day 1 normal LV systolic function, 84% of patients with indeterminate function. While applying the 2016 guidelines, this percentage dropped to 30%. It's basically the same here, from 76 to 16, here from 50 to 6%, here from 72 to 11%. So at least we can say with the new guidelines, we are able to classify patients and stratify their diastolic function a bit better. Okay, let's start now to move a bit to the physiology. And to move to the physiology, I show you this video if the video wants to work. It doesn't seem to work, but it's okay, because I have this screenshot that moves from a normal LV diastolic function condition with a steep relaxation of the left ventricle and the normal left atrial pressure. We need to consider these two important items of diastolic function, the LA pressure and the relaxation of the LV. As you can see on the first degree here, you see that the left ventricle has a relaxation that is less steep, which produces then a lower amount of filling in the early phase, but the LA pressure are still normal. The troubles comes when the patient develops grade 2 diastolic dysfunction and eventually grade 3, because as a compensatory mechanism, the patient develops increase in LA pressure to restore a sort of normal feeling of the left ventricle, but this is at the expenses of congestion. Therefore, the patient will have pulmonary congestion, and backwards, of course, will develop gradually systemic congestion as a result of fluid retention and other biohumoral mechanisms. So basically, the second degree has both the impaired relaxation and the increase of LA pressure, left atrial pressure. The restrictive pattern, to be honest, is a pattern that we don't met very, very frequently in ICU. And in this case, the patient is really, really, really sick and really in trouble. Maybe you see more in the cardiac ICU, but these are the patients that are very difficult to wean from ventilator and with a very, very, very high mortality. Now, if this was not simple enough, with my Italian friends, we developed a simplified approach just for educational purpose, which relies and wants to make an analogy between the left ventricular volume, the left ventricular pressure, and something that we maybe were used more when we were young, so drinks and alcohol. Sorry to use this joke, and the paper is almost accepted. It was basically under review and required very, very minor revisions. Will be probably available later on in Minerva Anesthesiologica. So what we want to imagine to show how there is an interplay between left ventricular volume and pressure, you have to imagine a normal condition in which there is a lot of volume in the ventricle, each diastole, that can pass from the atrium to the ventricle at the expenses of low pressure. Pressure as an analogy with the height of the glass. You see that progressively pressure increase and also the glass increase in its height, and gradually you see that there is a decrease in the volume that the ventricle of the glass can get. And as I was talking, I'm talking to my friends in Mexico. Of course, I did have to put the margarita first. And imagine that you are young and healthy, you can tolerate 3, 4, 5 of margarita and you still are fine. And then you get a bit older, you go for more fancy cocktail, and even 2 or 3 Aperol Spritz will make you a bit more headache. And finally, you will be able to tolerate only one of very mild alcoholic cocktail and so on. I mean, I made this kind of joke that can be a way to remember this interplay between LV volume at each diastole and LV pressure. Hopefully this will help remember a bit more how there is a progression in diastolic dysfunction. Let's now move on the evidence on science and what we know about the influence of LV diastolic dysfunction on patient outcome. And before moving to the critical care patient, even though these data are a bit old, please do remember that up to 50% of patients with pulmonary edema that arrives to the emergency department have a preserved LV systolic function and a normal mitral valve. In other words, these are data from the New England. In other words, these patients develop pulmonary edema secondary to diastolic dysfunction. And indeed, 50% of our failure hospitalization at normal ejection fraction, so therefore it's diastolic heart failure, And the prevalence in the population, I mean, this with the past guidelines, but with the new guidelines is probably something similar. It's 4 to 5 times higher than the prevalence of systolic dysfunction. Now, we have definitely evidence for significant impact of LV diastolic dysfunction on patient undergoing major vascular surgery, cardiac surgery, and general intensive care. But of course, as I'm talking to critical care friends, I'm focusing on the general intensive care outcome and therefore on the evidence. So this paper for me was very, very important because it was the first paper evaluating as a meta-analysis the association between echocardiography or anyway from cardiac performance and mortality in a patient with severe sepsis and septic shock. This meta-analysis by Stephen Wang in Sydney included 11 studies and on the assessment of LV function, and 5 studies on the assessment of RV function. And when you look at the performance of systolic function on the left side of the graph, you see that there was no difference between in survivors, septic patients surviving according to the LV performance. However, you see that there is a trend because the p-value you cannot see very well, maybe 0.052, so it's very close to be significant, and it favors survival in those with lower systolic function, lower systolic performance. And this is it may seem counterintuitive, but actually is not, because patients with hyperdynamic LV systolic function have higher mortality. In this regards, there is a paper from Paonessa in critical care. Moving to the right side of the slide, the RV systolic function does not seem at all related to mortality in septic patients. So I said this paper was very important for me because it did trigger the idea to evaluate with meta-analysis what are the outcome of a patient according to diastolic dysfunction. And in this meta-analysis we made with Maurizio Cecconi and other friends in St. George Hospital, we included 7 studies where LV diastolic function was assessed by tissue Doppler imaging. And we also took data for systolic function from 5 of these 7 included studies, assuming that these studies evaluating LV diastolic function had a higher degree of expertise for the echocardiographer and therefore a more reliable assessment. And what we found that diastolic dysfunction was significantly associated with mortality, while systolic dysfunction was not. And therefore, we went further and we did look as the tissue Doppler imaging assessment is the one that is more promising in patient with critically ill patient. We evaluated whether E prime and E prime ratio were associated with survival. And in this regards, we found more studies, like 16 or 17 studies according to the forest plot I'm going to show you. And we confirmed the hypothesis because basically we found a higher survival in a patient with higher E prime values, so better relaxation, and with lower E prime ratio, so patient with lower, possibly lower congestion. So as a summary of this evidence that I showed you on mortality and outcome in sepsis, we can gather that there is an association between diastolic dysfunction and mortality, while there is not association between systolic dysfunction and mortality. Okay. Once we find an association from statistical perspective, we need to try to understand why of this association. And I mean, I find it pretty easy to understand why diastolic dysfunction worsen the outcome of patient with sepsis, is because any patient, assuming any patient with diastolic dysfunction, we know that will benefit certainly from being in a condition of adequate preload, of sinus rhythm, and avoiding tachycardia. What happens in a sepsis condition, and even more in septic shock, is that the patient experiences relative hypovolemia, is tachycardic, basically by definition, and there is a lot of patient in sepsis that develops atrial fibrillation. In this case, is quoted between 20 and 23% of patients with septic shock. Let's move now from the mortality of sepsis to the weaning of patients in the ICU, regardless of the condition of sepsis, non-sepsis, whatever. And this is a paper that I suggest you to read. Is open access. It's done by the group of Xavier Monet, Jean-Louis Teboul. And what the authors did is to investigate the causes of weaning failure. And in critically ill patients, they were able to show, is a study of, I think, 250 patients. So this is the largest study we have on this topic. Almost 60% of the failures were related to cardiac dysfunction, as the author called weaning-induced pulmonary edema. And looking at the data presented by the authors, what we can see as a difference between a patient with weaning-induced pulmonary edema as compared to those that do not experience weaning-induced pulmonary edema is that they have similar ejection fraction, but a patient with weaning-induced pulmonary edema have higher E prime ratio, so possibly higher left atrial pressure. And when they move to the spontaneous breathing trial, they have, for the subpopulation monitored with PICO, they have an increase in global end diastolic volume, while in the other patient, this is unchanged. And even more importantly, from a clinical perspective, if you don't have echocardiography or if you don't have PICO device, is that after the maneuver of passive leg raising, the patient with weaning-induced pulmonary edema were mostly fluid non-responder. In other words, they were very, very well filled. While the patient not experiencing weaning-induced pulmonary edema, they were all fluid responder. They were a bit more on the lower part of the Starling curve. Therefore, what we did, we evaluated with Antoine Villard-Baron and other expert, Andrea Morelli, the association of echocardiography parameters with weaning failure from mechanical ventilation. And what we found that regardless the approach on weaning with T-tube trial or pressure support trial, we found basically that there was no difference in LV ejection fraction in predicting failure, while we found that the E prime ratio was significantly higher in those experiencing weaning failure. Similarly, the E prime was higher in patients with success. So in other words, what we found, and this is confirmed also by deceleration time, E wave, and other echocardiography parameters, is that patients with a better diastolic function had more chances to succeed in the weaning trial. On the other side, the LV systolic dysfunction evaluated by LV ejection fraction has a less clear role. Again, we find an association. We need to explain this association. And I think in this case as well, it's pretty straightforward. Because when you shift from positive pressure ventilation to negative pressure ventilation, it happens that we change the loading condition for the left ventricle into unfavorable loading condition because we have an increase in preload and an increase in afterload. The increased preload, if there is diastolic dysfunction, cannot be accommodated nicely, and the increase in afterload does not facilitate the emptying of the left ventricle, and therefore the increased LV and diastolic pressure and LA pressure by definition will bring the patient more easily in a condition of pulmonary edema. Therefore, it doesn't seem to be at all surprising that the same authors of the paper I showed investigated also a subpopulation of patients that, after failing a spontaneous breathing trial, were treated with ACE inhibitor and diuretics, and especially the use of diuretics and the move from preload dependence, from preload independence to preload dependence was associated with greater chance of winning success. Okay, we have defined what is a diastolic dysfunction in critically ill patient. We have tried to understand the impact of diastolic dysfunction on the outcome of critical care population. And finally, try to give you some suggestion on practical approach how to manage LV diastolic dysfunction. This is a paper that we wrote with Antoine Larbaron, Andrea Morelli, and Sabino Scolletta, and is open access free, so you can read it, and if you wish, and we'll give you some suggestion. And I will try to summarize this suggestion in the next 4 or 5 slides. And the first slide is a bad news because indeed we don't have a single drug that can rapidly improve diastolic function. So we don't have a magic bullet, and therefore we have to act with a proactive approach rather than with a pharmacological approach once troubles already happened. In the consideration of our approach to the patient with diastolic dysfunction, we have to consider a lot what is the physiology of the feeling and the left atrial pressure. So grade 1 diastolic dysfunction, as we said, has normal LA pressure. You see normal LA pressure in this regard, same curve as it is here. But you can see that as compared to a normal relaxation, very steep, here the relaxation is less steep, and therefore the early feeling is reduced, and the feeling due to the atrial contraction is increased. What this means? This means that if the patient develops atrial fibrillation, he will lose a considerable amount of feeling, and therefore the stroke volume may drop significantly. I will show you some clinical example later on. So grade 1 diastolic dysfunction, main suggestion is try to stay away from tachycardia and from atrial fibrillation. The situation gets more complex when we move to the grade 2 diastolic dysfunction, because in this case, not only the steep of the relaxation is impaired, but also you see the left atrial pressure with this bar I put here to simplify it is increased. The increase in LA pressure has restored a pseudo-normal LV feeling that is similar to the one you see here in the normal patient. However, try to imagine what happens with hypovolemia, which will drop down the bar of left atrial pressure and therefore will decrease the early feeling. And you know that this patient, for any patient, hypovolemia is a trigger of atrial fibrillation. So if the patient develops hypovolemia and then moves to atrial fibrillation, he will lose considerable amount of LV feeling. However, please bear in mind that the solution is not hypervolemia. It's not hypervolemia because this patient have very high LA pressure, and therefore if you increase the LA pressure further, you will develop pulmonary edema. So the fluid balance in this patient is very, very important. Now, from our simulation lab, I'm going to show you a couple of videos. So this is simulation, is not reality because it's difficult to be there and to make a video of a patient. But I am sure you have seen both patients with normal systolic function developing atrial fibrillation and remaining with a very good hemodynamics, good mean arterial pressure, not any sign and symptoms of the worsening clinical condition. And you have seen the same kind of patient with normal systolic function that once they move in atrial fibrillation, they crash and the blood pressure goes below 90, goes to 70, 60. You have to do cardioversion and so on. And the reason is just in the change in diastolic function. So this is a video that I really hope it works, and unfortunately it seems it's not working for the technical issue we had on the when we moved to another computer, so I'm really sorry for that. But basically is a video that shows that the patient moves in atrial fibrillation and the blood pressure remains roughly the same. While the other video was on, and again, is not working, I'm really sorry, but is another video of the same patient, but with diastolic dysfunction, so abnormal diastolic function, that moving in atrial fibrillation will have a drop in the mean arterial pressure and will require more urgent treatment. Of course, the faster is the atrial fibrillation, the worse will be the LV filling. As a suggestion, in the paper of the practical approach written with Antoine Belar-Baron, Scolletta, and Andrea Morelli, we give 5 main suggestions because as I said, there is no magic bullet. There is not a single drug that can improve LV diastolic dysfunction. The first one, let's start here, is to reduce afterload as much as possible. So there is no reason why a patient should stay with very high afterload if not indicated for any other reason. And in this regards, of course, we said that the patient should avoid arrhythmia and sustained tachycardia because this will increase the oxygen demand, but please keep an eye also on diastolic blood pressure. Please consider that the left ventricle is perfused in diastole. Therefore, you need to look at diastolic arterial pressure. And if the diastolic arterial pressure is very low, let's say elderly patient with very stiff arteries and so on, then we need to consider to increase the mean arterial pressure, to use something to increase the vascular tone. As I said, fluid must be administered cautiously. Both hypovolemia and hypervolemia are dangerous in any critically ill patient, and this is even more important when diastolic dysfunction is there. Finally, we said that there is no magic bullet. All the inotropes, most of the inotropes have a negative effect on diastole, so have a negative lusitropic effect. Maybe in this regard, the best one will be levosimendan, which can have a favorable effect on diastole, but the reason to start levosimendan should not be based only on diastolic dysfunction. At least that's my my practice, unless we are talking about a patient with restrictive pattern, and that will be very complex patient to be managed. But certainly we need to know that when we start adrenaline, we worsen diastolic function. When we start milrinone, there is conflicting evidence, but the LV diastolic function probably does not improve. So as a conclusion, diastolic dysfunction is very common, and we have seen that it affects the outcome of critically ill patients. The assessment requires training, but considering that we could use only the TDI variables, this has become a bit easier over the past years. And to manage the patient with LV diastolic dysfunction, I would try to to keep things very simple, to maintain an optimal feeling, avoid tachycardia, atrial fibrillation, and keep sinus rhythm as much as possible, and remember about the adequate coronary perfusion. And with this slide, I thank you very much for the invitation, and I'm open to any question from the panel.
Thank you very much, Filippo, for your presentation. We thank you very much for joining us in this session. We have now going to move to some of the comments from our audience. In this case, we have two excellent colleagues, Dr. Karina Rosa Sanchez. She is joining us from Tijuana. We have Dr. Paola Romano, intensive cardiologist, that join us as well. Thank you, doctors, for joining us. We really thank you for being here with us. Dr. Karina, maybe you want to start with a comment. We are very, very thankful. Thank you, Dr. Calderon. Thank you to the Colegio and Dr. Sanfilippo for sharing with us this presentation. I would like to start by highlighting the importance of acknowledging the diastolic dysfunction in the left ventricular for a critical patient, because besides all the causes that Dr. Filippo mentioned, it is also present in two of the conditions that we see more frequently in our intensive care. On one hand, in those patients with septic shock, and also those that are in mechanical ventilation. So bearing this in mind, as intensive care specialists, we are forced to escalate the treatment in echography, electrocardiography, because we see that it is not enough with a basic assessment, with a qualitative basic assessment, but we do need quantitative assessment that allow us to make any adjustments during treatment. I would like to ask Dr. Sanfilippo, what is your opinion regarding carrying out an electrocardiograph and start an echocardiography for all patients that get into the intensive care unit, or to be able to assess the degree of dysfunction whenever we have the patients with diastolic dysfunction?
Okay, thank you for the question. I mean, regarding the, we, at least in my unit, do electrocardiography, of course, in any patient at admission, and the echocardiography is done as soon as possible. This depends really on the skills of the consultant in charge. Okay. What I would say is that the reason to do echocardiography on admission shouldn't be to assess diastolic dysfunction, but should be to get an understanding of the condition of the patient from, let's say, what is the reason for shock, or what is the cardiac condition. Even a patient that comes with isolated respiratory failure, you need to understand whether there is some degree of acute cor pulmonale, if there is a patient with RV hypertrophy or not. So, I mean, generally speaking, we are moving to a wide use of critical care echocardiography. Whether the assessment of diastolic function is basic or advanced, at the moment is advanced. However, I cannot exclude that in the future will be regarded as basic, because you just need to do a tissue Doppler assessment of the myocardial wall. So it's just a very few seconds, at least if you do the simplified assessment, E prime and E prime ratio. The other comment is that we are conducting a study trying to understand the evolution of diastolic dysfunction from admission over the the first 24, 48 hours, and then before and after the weaning. It is complex because many patients do not arrive to the weaning, okay? But we want to understand how LV, diastolic dysfunction, is present at the beginning and how it evolves across the, so it's a longitudinal study. Because it may be prognostic, but also because diastolic dysfunction at maybe not clear at the first echocardiography you do, if the patient, let's say, is very hypovolemic. If the patient is hypovolemic, may have lower left atrial pressure, but once you restore the conditions of bulimia, then maybe you will see that the patient has normally high pressure. On the other side, it's possible the other way around, that you have a very much collapsed lung and so on. Once you use PEEP, you recruit and so on, then tracheostomy regurgitation may even decrease, even though you have mechanical ventilation. So, I mean, what I would say is you do echocardiography as soon as you can if you got skills on a patient on arrival, to improve the management from many perspectives: fluids, cardiac function, use of inotropes, use of vasopressors, and so on, make diagnosis for shock, and then getting an idea of diastolic function over the next 24, 48 hours, once the patient is a bit more stable, can be valuable.
Karina, I don't know if you have any further comments. We can either continue and coming back to you, or if you have any further questions. Not now, thank you. Dr. Paola, maybe you want to make a comment or something to add to Dr. Filippo? Thank you, Dr. Filippo, for this passionate conference here. This is something that we have gone through in our cardiac specialty, and how important it is to measure the diastolic function. Before, cardiologists, we will only care for, okay, we did not get the parameters, there were limitations with the transmittal fluid because of when we cannot quantify the diastolic function, but now we have evolved and we want to be more stringent in terms of the echocardiography study. And I like the fact that we have the simplified approach presented by Dr. Filippo, helping us to sort out our patients. We have grade 1 as well as a normal grade, and those that are completely on the other side, that are easy to identify with a EE ratio. So the part of the groups in the middle are the ones that we have to seek the parameters to understand where are we going to be grouping them. And the importance of grouping the patients is to understand that a patient with a cardio disease, especially when in the state of ventilation, I would like for Dr. Filippo to highlight going from avoiding the low pressure, and I believe that it is really important to put them into a group in order to manage them in a whipping process. So something else that we would like to mention is that diastolic dysfunction has been understood with the time by us. It is not passive anymore. This is just part of the cardiac function. This is an active process that involves the calcium, sepsis, bulimia, and definitely is very passionate. So I would like Dr. Filippo to talk about the weeping process, not losing a positive pressures in those patients that have high pressures in the left ventricular, also considering tachycardia and and all the different factors that you mentioned. Thank you.
Thank you. Just a quick one is on weaning process you meant, because I have some issue with the audio. Is a comment on the weaning process?
I was just wondering for you to highlight or help us to identify those patients with diastolic dysfunction that are in a weeping process with increasing of pressures of the LV, and bearing in mind all the things that have to bear in mind, not having tachycardia, and what would be the parameters that will help us to identify this group of patients, where the electrocardiographic patients help us to assign them or classify them in certain degree of diastolic dysfunction, and to highlight that it's important not to lose the positive pressure when we carry out a weeping process.
Okay, so thank you. Sorry, I just had a bit of noise in the audio and I couldn't catch a couple of comments. So there are many things you said and that are very interesting. I will go through this. So first one, very important, that diastole is an active process, and indeed there are some animal studies that shows that if you induce ischemia, then the diastole worsen even earlier than systolic function. This is just an example to see how diastole suffers from ischemia more than systole. Okay, that was the comment. For instance, keep a good diastolic pressure for a perfusion of the left ventricle. Regarding the weaning process and positive pressure and so on, I mean, approaching the patient that has to be weaned from the ventilator, we need to consider a few things. First of all, as shown in the study by Liu, if the patient is preload independent, so the patient is very well filled, whatever you use, if you use the inferior vena cava is not collapsible and is dilated, whether you use a pulse pressure variation or stroke volume variation and is in the range of 3, 4, 5. So if the patient is not preload dependent, this is a patient that is at risk of pulmonary edema. This probably regardless the presence of diastolic dysfunction, because once you move from positive pressure ventilation to negative, there will be an increased venous return, and if the patient cannot accommodate that venous return, will have congestion, will develop pulmonary edema. And in the same paper by Liu et al., they showed how good could be a diuretic therapy, moving the patient from preload independence to preload dependence. So making it simple, you need to make the patient a bit more empty from a volume status when he has to face the weaning from mechanical ventilation. In these regards, however, keep in mind that the failure from the ventilator can be due to muscular issues, from weakness. And unfortunately, we don't have a magic bullet for that. It can be due to other respiratory conditions that can be optimized, use of bronchodilators and so on, then use your stethoscope and et cetera, and also to the diaphragmatic function. Regarding the diaphragmatic function, there are some studies on levosimendan that should be able to improve diaphragmatic function. To be honest, the studies are controversial and they don't show a good improvement of diaphragmatic function with levosimendan. However, there is a study by Calzi et al., which is interesting and is not on diaphragm, but is on the use of levosimendan, where they had 11 patients that failed weaning, and they were started on levosimendan. And 9 of 11 patients, if I remember the numbers correctly, were able to be weaned from the ventilator. Not only the question on numbers, but if you look at the echocardiography parameters of this population of patients that started levosimendan, there was mainly an improvement in diastolic parameters, much more than the improvement of systolic parameter, which was roughly the same, but E prime and other parameters improved significantly. So this could be an option if available. I'm aware that levosimendan is not available in all the countries, and also it is expensive. I don't know whether in Mexico levosimendan is approved or not. In UK, when I was working in UK, it wasn't approved, so you had to go through special requests to get levosimendan and so on. So in summary, we need to use a lot of physiology. Finally, think about the role of PEEP, because if we have a nicely opened airways and so on, and the airways are not too much distended, and in this case we have an optimal pulmonary vascular resistance. If you stretch too much the airways, of course, you will have an increase in pulmonary vascular resistance. So if you do use exaggerated PEEP, but what happens on the weaning is that often the patient develops some collapse. So you lose PEEP. And also in this case, with the alveoli that collapse and becomes all crushed, then in this case, you have an increase in pulmonary vascular resistance. So in this case, there is an increased venous return to the right side and an increased afterload if you get collapse. So one option for the fragile patient with diastolic dysfunction, with RV failure or RV suboptimal function, will be to extubate them in non-invasive ventilation to be a bit more gradual. And also the non-invasive ventilation will still give you some positive airway pressure for in order to avoid a steep increase in the afterload of the left ventricle. So in this case, you have a more gradual transition from the positive pressure ventilation with a tube to a spontaneous ventilation.
Correct.
I hope I have responded to the comment.
Yes, thank you.
Thank you, Filippo. Thank you, Doctor. Maybe Paola, would you like to make any further comments? I just wanted to mention, because asking the echocardiographer a full diastolic assessment, and this is, I'm saying this because I know a lot of specialists will be joining us. We need to understand that a full measurement helps us to make decisions and to assign or classify our different patients according to risk. Okay, thank you. Thank you, Doctor. I would like to make some comments and questions to Dr. Filippo.
Filippo, first of all, I really thank you for joining us, Filippo. Well, it's very well known that the evaluation of diastolic function, Filippo, I think you agree with this, requires an advanced training. It is not part of a basic cardiac ultrasound. It requires advanced training. It's part of the advanced critical care echo. And sometimes, or most of the physicians, maybe depending on the situation, depending on the country, etc., not all the physicians are able to evaluate in a right way the diastolic function. So in terms of the importance of diastolic functions or diastolic function in the critical care setting, maybe for the physicians it's very important the diastolic function in terms of weaning from mechanical ventilation, because as we know, the diastolic function is very important in the setting of weaning from the ventilator. So in your opinion, when the physician Filippo is not able to evaluate the diastolic function, in the night shift and so on, maybe the physician it cannot require the echocardiography from the echocardiographer cardiologist. So, do you think that the pulmonary congestion is more important than the hemodynamic congestion? Because as we know in certain studies, the pulmonary congestion has a higher uh, rock curve. It can be more specific and more sensitive than the hemodynamic congestion, because as we know, the filling pressure can vary according to the chronic states or and many other factors. So in terms of winning from the ventilators, maybe the most important is to evaluate the pulmonary congestion, and we can assess it by using, of course, lung ultrasound. What do you think about it?
Excellent comment. So yes, I think it's very helpful. Um, if you, I would say that if you don't have any echocardiography advanced skills, then if you're able to evaluate the inferior vena cava and the lung ultrasound for assessment of B lines, that could give you some very practical suggestions. So it's very good. There are some papers that are trying to, I have reviewed one recently, that are trying to correlate diastolic dysfunction and pulmonary congestion. Now, to be honest, I think that's the issue is that we need a lot of numbers to understand really the correlation between these two things, and I'll tell you why. First thing is that one of the key point will be: is your patient a patient that has been intubated for pneumonia, or your patient was intubated for something else, for urinary sepsis? Did the patient experience a respiratory failure, or was just in septic shock due to another source of sepsis? Okay, this because in that case you don't know whether the lung congestion is related to the pneumonia itself, or is related to an increase in LA pressure and backwards pressure to the lung. The other point is that one of the issues is that more than looking at whether diastolic dysfunction is present or not, I would look at if grade 2 diastolic dysfunction is present or not, because is that the time when you have an increase in left atrial pressure. And is the increase in LA pressure that really favors the congestion and pulmonary edema. So I think diastolic assessment on its own can be valuable, of course with the systolic assessment too. Assessment of lung ultrasound and eventually of systemic congestion with vena cava, or Philippe Rolla is doing a lot of study with the Vexus and so on, can be valuable. Of course, the more parameter you get and the more you can integrate this parameter will be, the best. But I understand that it's difficult nowadays to have an ICU with all the doctors trained in advanced echocardiography, advanced, lung ultrasound, and able to do Vexus and so on. So overall, I think it's just the same with the hemodynamic monitoring. Hemodynamic monitoring per se does not cure the patient. Is the understanding of the numbers that are provided by the monitoring and the integration in clinical practice with the appropriate algorithm and judgment that can make the difference. In other words, making diagnosis or not of diastolic dysfunction doesn't mean anything if you don't apply all the proactive approach that can help to have a patient on the best condition to have the weaning or whatever, just the ICU management and so on.
Yes, Filippo, thank you. Actually, it's important because we have to keep in mind about the lung water congestion cascade. The diastolic
Yes.
function is the preclinical stage evaluating the diastolic function. I think it's important previous to show pulmonary congestion. So that's why maybe this is very important for the physicians at the bedside. Filippo, we are really, really happy for joining us. I would like to hear from my colleagues if they have another question or comment. Karina, do you have any other question or comment? Thank you so much for joining us also.
Thank you very much. All these, it's very interesting. And also, every time we highlight the importance of diastolic dysfunction, we have to move to the cardiac cycle, that it was underestimated and it was not well diagnosed. And also, besides acknowledging, we see that it is associated with worst scenarios, especially mortality. And when we can identify, we can manage patients appropriately. And as we have heard from Dr. Filippo with guides and recommendations from 2009 to 2016, we understand that there are limitations for identifying these algorithms. So I would like to ask Dr. Filippo if you consider it is necessary to develop or to reach a consensus focused on critical patients with the aim of standardizing diagnosis and to decrease the standardization of the studies that are being done about this topic?
It's a difficult question. It will be assessed at some point. The issue is that it's very difficult to understand where to put the limits between basic and advanced, you know, because there is no agreement on every single point between different consensus and societies and so on. From my perspective, yeah, echo is something that the more I was doing, the more I was trying to do something else, you know. And to be honest, using a pulse wave Doppler through the mitral valve may seem relatively easy, and I don't see any big difference that putting the pulse wave Doppler with different setting on the myocardium to understand the velocity of contraction and relaxation. So this is what I'm saying is that it's difficult to say you stop here for the basic and here you are advanced. It's just a continuum of learning. In diastole, I do understand that it should be regarded as advanced. But I would encourage anyone doing echo to try to evaluate E prime and the E prime ratio that are pretty easy. Whether the studies in the future with more and more patients will tell us that this approach has correlation with prognosis, then this will be a boost and will make more likely that we will study more and more the diastolic function. And another comment is that currently, I think for diastolic function, we are in a stage where we use the same parameter that our friends cardiologists use with a patient that is walking to the hospital and getting their own echocardiography awake, putting the elbow up and, you know, getting their scan. It's not the same in ICU. You get ventilation, the patient are sick, they may have cardiac ischemia, they may have whatever condition that acutely worsen their diastolic function. And using the same cutoff is not probably the best approach, is the best solution we can do at the moment. I make you this example. In my unit, we had relatively low number of COVID patients because my unit was one of the last of the city to be converted into COVID. And my personal idea, I've got the data, I'm doing analysis and so on. The idea and the impression is that the E prime values were very low. Does this mean that these patients were not sick? Does this mean that these patients were not having diastolic dysfunction? I don't believe so. It's just the results of them being not eating and drinking for a few days, having had 39 degrees of temperature for days, and being on a CPAP hood for a while, without a sip of water, and therefore with a very low amount of IV fluid to avoid worsening of their oxygenation parameters. So that's why they had very low E prime ratio, because they had low left atrial pressure, because they were on the very low, on the very hypovolemic side of their function. So in other words, I don't think we have a magic solution to assess LV diastolic dysfunction, and we need to do probably a collaborative efforts, collaborating and collecting lots and lots and lots of data, which is not easy in critical care. Our friends cardiologists have more chances to collect data on 1,000, 2,000 patients just with a collaboration between 5 or 6 big centers. We don't, and our population is very heterogeneous. Pneumonia, non-pneumonia, shock, not adrenaline, adrenaline, or other inotropes, and so on. So at the moment, I think we still need to do a lot of clinical research to understand what are the best parameter and the best cutoff to define diastolic dysfunction. So it will likely remain an advanced echocardiogram that will assess LV diastolic dysfunction in critical care, mainly because apart from applying guidelines, you need to apply and understand all the pathophysiology behind of your critically ill patient and why the diastolic function can be that.
Okay, Filippo, thank you so much. We really appreciate your analysis, your fantastic analysis. Thank you, Filippo. Well, I would like to hear from Karina the last take-home message in order to finish this session. Karina, please, thank you for joining us once again.
I just want to emphasize that regarding treatment, we must bear in mind that we should not see diastolic dysfunction as a pathology itself, and that the management has to be focused on all the aspects that the doctor mentioned, limiting liquids and to decrease the post load, and so we can decrease the risk of a patient presenting any deterioration.
Thank you, Karina. Thank you for joining us. And Paola, do you have some last words for our Mexican and Latin American audience? Thank you for joining us, Paola.
I just want to thank Dr. Filippo. Excellent presentation. And let's keep on moving forward regarding this very passionate topic, their diversity in terms of treatments. We can have a patient assessed in the morning with diastolic dysfunction, with diuretics, and the scenario can change in a few hours later, but identifying patients with the risk of developing lung edema and things like that is also important. We also have other methods such as the lung um, ultrasound that are helping us and enable us to identify patients and assess them. Thank you, Dr. Filippo. Thank you to the Colegio for the invitation.
Thank you all. Thank you, Paula. Thank you, Karina. Filippo, before finish it, could you please tell us the last message to our Mexican and Latin American audience?
Well, last message from me, my side, would be to be curious and to learn. You know, the ultrasound probe is the stethoscope of 20 years ago, of 30 years ago, I don't know. So nowadays, everybody should be able to do some ultrasound assessment. And once you start doing it, it's not that difficult. And there are a lot of tools on internet and books and tutorials to learn echocardiography, lung ultrasound, and so on. I'm sure you can still go to your cardiologist colleague and say, can I do some echo with you, if you need some tutorial. And then once you start, the learning curve will be very steep, and you will quickly be able to do all these assessment and so on. It will not take too much time. Just for example, one of my trainees that did follow me very tightly in moved in 1 month to be very independent in systolic and diastolic assessment of function, RV assessment, and so on. So it takes a bit of application, and for young colleagues, you cannot imagine yourself not doing ultrasound and echocardiogram in the next 5 years or so.
Thank you, dear Filippo. We were very happy. Thank you for your fantastic presentation. It was a great pleasure for having you. Thank you for accepting our invitation, despite all the gap time between us. You know, thank you, really, thank you.
Thank you. With this, we finish our monthly presentation. We are very happy. We would like to thank Dr. Karina, Dr. Paola, and our international speaker, Dr. Filippo Sanfilippo from Italy. This is a pre-recorded session because of the time zone difference among these two countries. Thank you. We will see each other in the next month. It would be very interesting for our community of the Colegio Mexicano de Medicina Crítica. Thank you. Have a great night, and let's move forward with all these sessions. Thank you.